Hi, welcome to my podcast, and I'm happy to have my first guest to my very first episode of Eye to Eye podcast, Dr. Bojan Kozomara, PhD. Dr. Kozomara is the co-owner as well as medical director in Svetlost Eye Clinic in Banja Luka from Bosnia and Herzegovina. He is mainly an anterior segment surgeon as well as a specialist in cataract and refractive surgeries. He did a lot of publications and continues his scientific work up to date. Yeah, very good. So I want to start, as I told you already in the mail, with the LASIK correction and refractive surgeries, intraocular and extraocular. By extraocular, I mean the corneal refractive surgeries. So just a few days ago, I came across one article where they compared FS LASIK with ICL for myopic patients. And in order to be more specific, it's like a highly myopic patients. And I know that you also, you're very tend to do myopic corrections with ICLs, right? And do you have your own specific opinion why you would like to do that? Or should I be always more specific with ICL refractive surgeries because this is mainly for high myopes? What is your point about that?
Well, I will start with the fact that my eyes were operated on back in 2009. I had -9 on my right eye and -5 on my left eye. If I was to choose, or if I had a chance to choose between the ICL, between the vision ICL that we have right now and LASIK, I would most definitely choose the ICL. Why? Because with the high myopic ablations, you have very deep ablations, and you will most definitely have post-operative dry eye in mainly or all the patients that you operate on. So I had for a very long time a dry eye on my right eye where I had -9. The other issue is that you will have to touch too much of the cornea. You will have to remove too much of the corneal stroma, and by that fact you may have post-operative complications, as I just said. Also, you may have an unsatisfied patients. With the ICL lens, you will be able to remove the lens if the patient is unsatisfied, and you will not touch the cornea that much, so you may reduce the number of post-operative unsatisfaction that patients may have.
Okay, so did you have these dry eye symptoms, in general, dry eye kind of condition before the surgery, or you had it?
Basically, no, because I did wear contacts for a very, very long time since I was 8. But I did not have that much of a dry eye right after the LASIK. I had a severe dry eye after the LASIK, mostly on my right eye. I think it is because the LASIK ablation was big, actually, and my corneal nerves could not recover that much as they did on my left eye.
And what would be your maximum age range when you would say that, okay, until that time I would consider for high myopes ICLs. After that, I would not do that.
Well,
do you have this kind of nomogram for yourself?
No, I choose that from one patient to the other, because I think that there is no specific, let's call it a rule, that you can have for each and every patient, because you may have patients that have a high myopia and they do not want to do LASIK whatsoever. You also have those that would like to do only LASIK, and they do not want to have any type of intraocular implants. So what I do is that I talk to the patients. I talk a lot to the patients. I want to learn as much as I can about what they want to achieve, what they expect, and what can I do for them after I examine them. I would not do phakic intraocular lenses after the age of 40 to 42, because these patients in 3 to 5 years will have a presbyopia, and having the ICL in their eye will not have that much of the effect, and I will not do it before the age of 18 to 21.
Before 18 to 21. Okay. You have partially answered actually my question when I wanted to ask that, for example, if you would have a patient, high myope, and based on the examination and also the pupil size, this is also another thing which I also want to touch. So when you would say that, okay, the pupil size of a patient is large, and maybe in this particular case, it's better for this patient to have ICL, but the patient has a fear to have intraocular surgery and tends to have LASIK surgery. So I believe that, of course, communication and explanation is very important, but how to be with these kind of patients? Or you just decide to take a larger optic zone in order to avoid any kind of
usually do that,
complications?
yes. I usually do that, and it also depends on the level of visual acuity that they have. So if you have an amblyopic patient, which has, for example, -6 or -7 diopters of sphere, and they have very large pupils, maybe 6 millimeters or even larger than that, they would most definitely benefit from the LASIK, even though they have so much larger pupils, because they are amblyopic and they will not see any glare halos as would do all those that have 1.0 VA or 20/20 as we also call it. It also depends on what patients do. If they are in their cars a lot, if they drive by night a lot, I would not do LASIK. I would most definitely try to get them into the ICL lenses.
So there is an opinion that ICL has a very good potential to substitute FS LASIK or in general current refractive surgeries due to high optical and visual quality of ICL implantation. Do you think this is because of direct intervening in the optical system, that we directly intervene in the optical system by implanting the lens behind the pupil, because pupil is also an important part of optics in the eye? So do you in general think that there might be slowly a tendency when these LASIK surgeries will be substituted with intraocular lenses implantation?
Well, it is the same thing as if you have the patient who wears glasses and who would like to wear contacts. So when you have the patients that, for example, have -2 and you put them -2 glasses on, they will see, like great. But when you put -2 contacts on their eyes, they will tell you that they see excellent, because the contact lens comes directly onto the eye or onto the cornea, and they imitate the normal vision of the eye. So you will have much larger visual field. You will feel as if there is nothing around your eyes that blocks your vision. So I think it is the same thing as with the LASIK, comparing it to the ICL. Also, you reshape the cornea with the FS LASIK or any type PRK or LASIK that you will do, which basically thinks or means that you will change the HOA or HOA or higher order aberrations, and you will also change the quality of vision that one patient sees. However, that is not as important to high myopic patients as it is for example, hyperopic patients, which are used to see very good at far, but they cannot see good at near. So when you reshape the cornea in hyperopic patients, they will most definitely see some or have some type of photic phenomena, glare or halo, and most of them will be very unsatisfied. So I think that maybe in the near future, LASIK will be only done to myopic patients. They may also be done for patients with low to mid astigmatism. I don't think that we will do it much more in higher astigmatism. By that I mean higher than -3 or -4 diopters. I don't think that it will be done that much for hyperopic patients. And I think that we need to find a totally new way to correct hyperopia for very young patients. By young, I mean those from the age of 20 to 21 until the age of 40 to 45.
Yes, you already answered my question when I asked about the pupil, and but in general, if I missed something, so what would be your range of pupil size when you would say that this particular patient is not gonna have FS LASIK because of, I don't know, large pupil?
For the pupil size, if you are asking for myopic patients, I would not do them, and if they have 20/20 vision, I would not do FS LASIK for those patients where the pupil size in scotopic conditions is larger than 4.5 to 5 millimeters. So each and every time we do pentacam exam, we always do it for LASIK or laser patients in scotopic conditions, because I want to see how much will that pupil enlarge if my patient is in the car and he's on a highway and it's middle of the night, and I want to see if he or she will come back to me in a couple of months and say I cannot see anything at night when I'm in my car. So for 4 to 4.5 or maybe even 5 would be the highest level of pupil dilation that I would take for FS LASIK. However, if you have an amblyopia patient which sees maybe 20/60 or 20/80, they want to improve their vision on that eye or on both of their eyes. I would consider them if they have pupils that are larger than 5.0.
So, of course, as I understood, and as I also believe that it's very important to ask the style of patient's life. What is he doing?
For multifocal lenses, for EDOFs, for ICLs, for LASIKs, you have to talk to the patients, and that's the primary thing that you need to do. All the rest of the stuff comes second. If they have or they do not have healthy eyes, what is the size of the AC depth? What is the pachymetry? All other things. But the only issue that you need to talk to the patients, and you need to see what they do, how they do it, where they live, how they live. I actually had a guy who was a driver for our minister here, and he could only see 20/80 and 20 over 100 on both of his eyes, and I asked him, "How do you see?" And he said the minister does not take any night drives. He doesn't have any night meetings, and when is the daylight, I see excellent, but during the night I cannot see anything. So it is very important for you to talk to the patients and to see what they want, how they want it, what they want to achieve, and you need to explain to the basic details each and everything that they can expect. So when I do this, I tend to show to the patients the worst case scenario every time. I will not tell them that the surgery will be perfect, that they will see perfectly, that they will not experience anything. I want them to understand that they can have some side effects, and that these side effects can affect their lives.
Yes, I also believe that it's very important. And do you have a routine to check the dry eye symptoms, even if the patient doesn't have any complaints? Do you do any tests, dry eye tests before the surgery?
Yes, pre-operatively to each and every patient that comes to us that wants to do either LASIK or intraocular lens implantation, we do Schirmer tests. And according to that, if the level of tears is less than 10 millimeters, we do not do surgery. So if we see that patient has some inflammation, or that we can get it much or less better than it is, then we put them onto the medication drops, and we see him month or a month and a half.
So the results of Schirmer tests basically decide also at some point if you're gonna do surgeries or not. Do you do this kind of specific approach for everybody, or do you also differentiate between men and women? Because I have the feeling that women have somehow more tendency to have dry eye syndrome. Is it? Did you notice something like that too?
We actually do it to all of our patients, regardless of their sex, gender. But maybe we can see that women are more prone to developing dry eyes after the procedure than we do see them before that. Why is that? Particularly, or maybe due to the hormones that women have and we males do not have it, at least not at that level. And I think that those hormonal levels may affect the development of dry eye. We should do that in each and every patient. We should again talk to them and explain to them that they may be connected to those small bottles of artificial tears for a very long time. I was dependent on them for about a year after my eyes were operated on.
I see. So now just a short information about myself, because I have extremely dry eye, and I have just a very small amount of astigmatism. But I'm afraid to have any LASIK surgeries, because I'm kind of sure that after the surgery, I'm going to have it even worse. Because without drops, there is no day for me. I drop them every single day, twice in a day. And yeah, when I don't drop them, I realize that I have dry eye. I don't know, maybe also because we are constantly watching something or just reading from the screen. Of course, this lifestyle also affects a lot. So what do you think? I mean, do you think I should consider it, or it's better not?
Well, you know what, each and every refractive surgery is basically elective. So you can do it or you can't do it. You wish to do it or you do not have to do it. So I wouldn't do it right now. I wouldn't risk it. If you still feel that you have extremely dry eyes and you've basically did anything you could to make it better. I don't know if you ever tried in Germany or in Austria, it is called e-curvis or e-curvis.
E-curvis, yes, e-curvis. No, I never tried it.
For an A, it is very good for people like you who did try everything they basically could. I think you take it for 20 days, 2 to 3 times per day, continuing and taking artificial tears, and you can see if you will have any benefit with those eye drops. You cannot do anything wrong to your eyes, but at this level, with so small level of astigmatism, I would not do it.
I mean, it's okay. Of course, with glasses I see better, but yeah. So let's continue.
Sure.
So then I want to continue with the FS LASIK versus microkeratomes. And I think you are using microkeratomes, right?
Mostly, yes.
Mostly, yes.
Mostly, yeah.
And yeah, so I will start with first question. So the literature review indicates that the femtosecond laser has a tendency to create a slightly thicker flap than intended, while microkeratome, while with microkeratome, the flap is thinner than intended. Did you hear something about that, and what are your thoughts in general?
It is basically true, because when a femtosecond laser cuts the flap, it cuts it evenly. When microkeratome does it, it does it like this. But femtosecond laser for many nations and for many countries and for many people is more expensive, and people here, at least where I live, cannot afford femtosecond laser LASIK because it would cost too much for most of them. So I did not see much of a difference post-operatively between the FS and the microkeratome LASIK. I could have chosen back in 2009 between the two, and I chose microkeratome for both of my eyes, because if you take the time that the suction ring is onto the eye in femtosecond laser, your patient has to be still and lie still for 20 to 25 seconds per eye. In microkeratome, I do the flap in 6 to 10 seconds. So if you have a patient which is much more scared, has small eyes, has deeply setted eyes, it is much easier for me to do microkeratome flap than to do the FS flap. The other thing is that you need to move patients. So if you have a laser platform where you have both lasers in one setting, you will have to move the bed from this side here to the other side here. For many patients, any movement that you do is scary. Third thing is that you have to do 4 procedures in one patient. So you have to do FS flap on this side and then on the other eye, and then you have to move the patient, as I said, and then you have to lift the flap, do the ablation on right eye, and then again do the same thing onto the left eye. For many patients, that is too much. And I don't think as in what is called now FLACS or femto laser assisted cataract surgery, many nations now see that there is no much bigger benefit in doing FS comparing to phaco or a microkeratome LASIK. I think that the only issue that we will have with microkeratomes is that the industry will stop making those microkeratome blades, and we will not be able to buy them, meaning that we will not be able to do microkeratome LASIK anymore.
Oh, really? Do you really believe that?
I think so. The same thing they did with phaco machines. If you take any company, they basically make you to buy a new machine after 10 to 15 years because they stop producing those what we call bags or systems for phacoprobes.
Okay, interesting, because there are publications. It was actually a new one from 2021 from someone. They compared FS LASIK with microkeratomes, and UDVA or anything didn't show any significant differences.
No.
Exactly. And even though some doctors, they still believe in the superiority of FS LASIK over microkeratomes, this superiority, let's say like that, was not proved. It's just a subjective opinion of doctors.
I respect all the colleagues that do FS only, but I don't see how. The only issue is that you will have much less complications with the flap if you use FS comparing to a microkeratome LASIK, because if the suction breaks in FS, you can suction the eye and the laser will continue where it stopped. In microkeratome, it is not possible. You will have to reposition the flap, and you will have to wait a month or month and a half and then do the new cut. It is true, but all the rest of the things, I don't see how FS benefits more than microkeratome LASIK. And on the other side, if you want to do one FS procedure, you need to pay what we call the license or the password to use the machine, which for us costs 2,000 euros to 200 euros per patient. Where in microkeratome you can buy one blade for 45 euros.
Okay, yeah. And what is the thickness of the flap with microkeratome, which you're using?
I do it basically for 90, wow. 90 to 100. You also have knives that will cut 130 to 140 microns.
Because in the publication which I've read, they said that there is also a difference between flaps, and obviously, which you already also before mentioned, that in microkeratomes they make like a meniscus shaped flap. Yes, and it's more homogeneous, let's say like that, in FS LASIK. Yes. And it was also mentioned there, because they evaluated all these flaps shapes post-operatively, that the thicker the flap of microkeratomes, the more meniscus kind of shape it has. So with 110, between 100 and 110, they have a less tendency to have it in this meniscus kind of, and 130 is more. And as you said, also 140.
That's so because you are taking much more stromal tissue. If you look at the cornea, they made the knives for 90 to 100 micron flaps, not to go that deep, and they have to cut it like this. But as soon as you go deeper into the cornea, you will have much more tissue, and they made it to go like this.
Yeah, it's like a safety, basically.
That's why, that's why the meniscus is much, let's call it bigger, thicker in those that are cutting 130 to 140 microns.
Do you have as a standard for everybody 100 or 90, as you said, micron, or do you adjust it also based on the cornea refraction or thickness?
I adjusted basically for each and every patient. Mainly in 90 to 95%, I do 100 microns thickness flaps. So these are the those that are 90 to 100 microns. If I have a patient or a patient that has a very thick cornea and has very low refractive error, for example, -1 or -1.5, I would then use 130 to 140 microns flaps.
Great. So, did you have, in general, the feeling, because there was another publication, they compared the outcomes, even though the UCDVA was not significantly different in any of the groups, I mean, FS LASIK or microkeratomes, but I don't know, they identified that the patients in the microkeratomes LASIK group had more tendency to have a myopic post-LASIK refraction. Did you see something like that in your practice?
No.
No.
If you use the right nomograms for each and every patient, I don't remember exactly, but I know that you do not change the amount of refraction that you will correct from -2 to -5. After the -5, you subtract -0.5. From -6 to -7, I think it's -1. From -7 to -8, it's -1.25, and from -8 to -9, it's, I think, -1.5. But if you do the nomograms correctly and you have the whole patient's eye in front of you and you analyze the corneal topography, I don't think that you will be able to make a myopic shift. However, I had a very large number of patients whom I corrected hyperopia. Mostly those from +3 to +4, +4.5, who ended up myopic. And I basically stopped doing LASIK for all hyperopic patients from +3 to +5, because many of them, if not any of them, will end up myopic, which for them is a disaster.
I realize that many surgeons are really hesitating correcting hyperopes. I mean, when it comes to this corneal refractive surgery.
I did it back in 2008, 9, 10, up to 2015. I corrected I did hyperopic LASIK up to +5 or +5.5. Then I saw that many of them will end up, as I said, myopic, and I lowered it to +4. Then I saw again that many of them have halos glare and they turn myopic in a couple of years. And now I do it only when I have to, and up to +2.5 to +0.275. I do not do it for hyperopes anymore.
So basically, if, for example, 36-year-old patient comes to you and he's hyperop since forever, and he asks you about refractive surgery, would you just consider, and he really desperately wants to have this, would you just consider an intraocular lens or nothing?
When somebody desperately wants to do that kind of thing to their eyes, send them back.
Okay.
Because those patients will never be satisfied.
Okay.
Avoid patients that seek perfection.
Yeah.
Because they will never be perfect, and they will never be satisfied, and they will never see, and they will always have something with their eyes. I would, depending on the level of hyperopia that the patient has, if he's a high hyperope, +5, 6, 7, 8, maybe 10 even, I would suggest them to do EDOF or EDOF lenses, because those patients basically do not have accommodation anymore. Yeah. Even though they are at the age of 36, right? They do not have, or they lost their accommodation for a very, very long time. They may be amblyopic, which means that I will not put the multifocal intraocular lenses into their eyes, because they will always be unsatisfied. Yeah. Or if they see good and they have +3, +2, +4, I would tell them to wait for a couple of more years, and then I would do either the EDOF or the multifocal lens implantation.
So basically, this would you also consider for presbyopic patients too?
Yes, yes. If I have a patient that is 46, 47, 45, they have +0.5 for far vision, and they developed presbyopia, I would suggest them either to do the EDOF lenses or multifocal lenses.
Do you do before multifocal lenses implantations any tests? Because I heard that there are some patients who cannot still adjust to this multifocality of lenses.
That is not actually true.
Okay.
I do the same exams as I do for any LASIK patient. And what I basically do is I talk to these patients a lot. I want to see how crazy they are, and what they want to do with their eyes, what they expect. If I have a patient who comes to me and he or she says, I want to see as I saw when I was 25, I send them back home, because those patients will never be satisfied. I need them to understand what are the limitations of these intraocular lenses. So for diffractive multifocal intraocular lenses, I always say that they may have halos glare, particularly during the night. So if they are in their cars and the other car comes in the opposite direction, they may see halos, glare, or starbursts. If they are not using their car during the night that much, they may be a good candidates for diffractive multifocal intraocular lenses. For the newest lenses that I use, synergy lenses, I also tell them that they may have a little bit of drop of contrast sensitivity. Their colors will be the same as they were, but they may seem a little bit grayer than they did before. If I have a younger patient, who is a professional driver, who drives during the night, I would suggest to him or her most definitely to use the EDOF lenses, because they will not have that many, or even if any, halos and glare, and they do not read that much those small letters, so they would be most definitely satisfied with the EDOF lenses. But what I do, I talk to them a lot. I show a lot of photos. I want them to understand that their vision will not be perfect, but they have to know that it may be much better than it is as it is at that specific moment.
This is great. Of course, I am sure you have a great experience in this multifocal lenses. Maybe we'll cover this in our next videos. I would love to do that because it's, I think, a huge topic to cover.
It is.
Yeah. So let's continue with and go back to microkeratomes and FS LASIK. So another study showed that also there is also a progressive thickening of the flap after LASIK over time in high pre-op myopic patients, and it was also correlated with the level of corrected spherical refractive error. So for every diopter of spherical equivalent corrected, 1.15 micron epithelial thickening was observed. Did you hear something like that? And this was like the first 3 months after LASIK.
Well, I'm not sure if maybe it is. I did not look into that specific study, but if you take the cornea, you lift the flap and you do the ablation on the stroma. You reposition the flap, and that micronic part of the tissue that you moved is not there anymore. So this cornea down there has to reconnect with this one, which is upwards. You will always have a water or BSS that will stay in that specific area. So what the eye does, it most definitely grows a bit of the tissue to fill that specific void that we have right now. You do not see that the cornea is maybe it is a bit flattened than it was, but I think that these two parts connect into their own way. I believe that I did not do any study of that kind, but I believe that there may be tissue growing or tissue thickening maybe from stroma toward the part of the cornea or the epithelium together with the Bowman layer where the flap is.
So what would make you, in your practice post-operatively, to measure the thickness of the flap? Did you have any this kind of situation, actually, when you think, okay, I would like to know what is the thickness of the flap now, even though that you know that before it was tended to be 90 or 100?
Well, my colleagues from Croatia, from our main hospital there, did a study. I think it was back in 2017 or 2018, and they've measured the thickness of the flaps, and they ended up seeing that microkeratome flaps were from 90 to 105 microns, and the FS were exactly 100 to 102 microns, meaning that it is true that FS flaps are much more precise as you set the laser machine on them, but in patient's view or in our view, it does not make any big difference. So the main issue is if the patient will see good or great or better after the LASIK, regardless if it's a FS LASIK or microkeratome LASIK. And on the other hand, you need to see what is their VA. If -5 patient can now see 20/20 or 20/25 after the LASIK, it is an excellent choice for them. I do not seek for perfection in all these patients because you will never find it. You can always find something that will not be good. When you touch the cornea, you will have higher HOAs in each and every patient. You cannot miss that. If you do the ICL, in a couple of years you may have a certain level of cataract. You will have a patient that will tell you that their vision is not that good as it was before. But the only issue that you need to see is if your patient will see better or not, and you have to find the right way, the right mechanism to make it happen.
Actually, we also covered this a bit, but I will still ask you. So I believe each method has its own complications and advantages. I mean, FS LASIK or microkeratome. But there is still no evidence for inequality or superiority, how I said, of either of the technique. But my personal feeling is that somehow femtosecond laser is like fancier, let's say like that, in the ophthalmological world, even though there is no differences of the results, outcome, as you said, patient didn't even realize. But
what kind of car do you have? What kind of car?
Yes, I have Renault Captur.
Excellent. If you take it with the basic equipment in it, and if you take it the full high leather air conditioning stuff, it will still be the same car, right?
Yes, and I am not into car. I even don't like driving, honestly.
Yeah, I mean, you now have colleagues in the United States. I actually talked to one of them a couple of days ago, and the issue was the femtos laser assisted cataract surgery. Many of them are leaving that concept because it is very expensive. It takes too much time to do, and the patient did not see much benefit of it. Okay, if you had a patient who has a smaller level of astigmatism, and you can do the LRIs, limbal relaxing onto the cornea. When the femto laser does it, it's much like better as if I do it by my hand. But the regular phaco, it is much faster. You know what you are doing. You will still do the whole surgery by yourself, and you still have to do the most of the surgery by yourself if you do the FS cataract surgery, and the patients cannot afford it. It is much more
extremely expensive
than it is to do a usual regular phaco. So I think that the industry will
affect it, right?
Take us by our necks, and they will use it because they will force us to buy the femto lasers, the femtophaco lasers, because they will stop producing the microkeratome blades and microkeratomes as well, and you will not be able to buy them. For example, I would like to find a guy who will tell me the big difference. Of course, there are small of them, but I would like to find a colleague surgeon who will tell me the big differences between the Centurion Alcon phaco and the Infinity phaco that we had before that. I don't see any. I don't see any. But you cannot buy those cassettes that we use, those systems that we use for Infinity anymore, and you are forced to buy the new phaco machine. So those benefits that they talked about are not that high and not that big as we thought they would be.
Yeah, so basically, no matter what doctors find easier or more practical, the industry somehow affects the demand.
Definitely. because the same price for FS laser is for me as it is for the guy in, for example, Vienna. Maybe the patients in Vienna can pay 2,000 euros per eye for a FS LASIK. Patients in Bosnia cannot pay that much. We will have to find ourselves somewhere in the middle.
Yeah.
When you see that the license cost, the cost for me to turn the FS on and to work with it is not the same for me because I have less eyes as it is for the guy from, for example, Boston, who has 10 to 100 times more eyes than I do. I cannot compete with him and have the same machine, the FS, and give the lower price for my patients as he can take it up for his patients. So again, I think that we need to find ourselves somewhere in the middle. FS is excellent, it is great, but you need to know that certain eyes or certain countries cannot use it that much as some others can.
I think there are also many doctors involved in this technology development projects.
When it comes to doctors and the industry, you can remember the last year's COVID vaccination, and we had an issue where it actually said that Pfizer made their vaccine in about a year. You and I know that takes 5 to 10 years to test that same vaccine and to see how it affects people. But we as doctors were basically totally out of it. Things move fast. Things move much faster than they were. I think that we as doctors need to find totally new testing models for the new technology, because we cannot test each and every thing that comes out onto our patient's eyes. We need to find some other things, maybe some kind of a softwares or some pork eyes or whatever, because it takes too much time, and the industry does not like when something takes too much time. They want it fast, they want it hard, and they want to, in the next 2, 3, 5 years, have a totally new issue that they will put into us or they will put in front of us and tell us, okay, this is the newest, the best, and you will make much more with this as you did with the other one.
Do you do PRK?
In 5 to 6% of my myopic patients, yes.
So what makes you decide to do PRK? Because I also know many surgeons who do only PRK. They don't do any flaps.
Many surgeons do not like to cut cornea.
Yeah.
And many surgeons are afraid to cut cornea. When you do the PRK, you can do it up to -4. You can do it up to 1.5 diopters of astigmatism. And you will have patients who will recover for more than a week. I tend to do PRK only for those patients who are not good candidates for LASIK, who have very thin corneas, and for the patients who are willing to sacrifice 7 to 10 days of their lives to lay back home and feel pain and feel itchiness in both of their eyes. So those are basically the patients that are not good candidates for LASIK, and they do not want to do the ICL.
What would be your advice for young, just starting surgeons in LASIK field? What would you advise you? So what is, when you look back now, when you just started LASIK procedures, what you would do different?
Go slow. Choose as much mentors, or have as much mentors as you can. Do not trust 100% the industry. Find your own way, find your own style, find your own machines or intraocular lenses that you will use. See what patients need. See what patients can have, see what patients can pay. Do not rush into groups of people that think the same. You have to be that specific person, that specific doctor, and you have to do it in your own way.
Thank you so much.